The most common question that I hear from people is, aren't you bribing them not to use drugs? Aren't you just giving away money?
The stimulant-involved overdose deaths in the U.S. have actually increased fourfold since 2010.
When you look at patients who are suffering from substance use disorders, you can see how that their ability to wait for the delayed gratification is compromised. The concept is to provide them with either money incentive or voucher incentive every time they reach a target. And it increases the likelihood that they will reach the target behavior. Some of the patients have so much ingrained that into their routine that they cannot now get sexual orgasm without using methamphetamine or cocaine. Contingency management works. It's the best treatment for patients with cocaine use disorder or methamphetamine use disorder. It's actually very simple. There are many barriers to provide contingency management from the stereotypes and stigma and from also the reimbursement standpoint, but it's nothing that we cannot overcome.
If you haven't learned anything, I want you to take one thing away, is that contingency management actually works. So when you can, please use it. Hello, everyone, and welcome back to the Transform Minds. Today, we have a very special episode. This is the podcast where we are exploring the real-world intersection between mental health, addiction, and transformative care. And as always, I'm your host, Dr. O. With each episode, we're taking a very thoughtful approach. It's practical, evidence-informed, and we're looking at how we can improve psychiatric and addiction care from our clinical settings to the communities that we serve. If you're new, here's the vibe. We have the Host RX where it's just me and you, and we're breaking down the different literature that I get to talk about. You can share what you think is interesting, literature that you want to break down, and I bring mine, and then we continue this discussion. We also have the Expert RX, where we have brilliant minds from the field of psychiatry, addiction, policymakers. They all come in and they share their expertise with us. We also have our very special kind of episode, which are the Lift RX. This is where the real life stories come in. They're guests who have lived it. They may also have exceptional education and knowledge about what they're talking about. In addition to the lived experience, they've survived it and they're reshaping addiction and psychiatric care because of this. So today, we have an Expert RX, and I'm so glad you're here, as always, ready to learn with me. We have stimulant-related deaths, particularly involving methamphetamine and cocaine, and they have risen sharply over the past decades. I can not even count how many times I've seen someone come in with cocaine intoxication or methamphetamine, causing some form of manic episode in an emergency room or even during an outpatient setting. But unlike opioid, stimulant does not really have an FDA-approved medication to help with this. So we're leaving clinicians, systems, and patients with very limited options. But today we have someone here with us that can help us discuss. We're going to examine the evidence behind contingency management, and we're going to unpack why it's important and why sometimes, or even in some of our practices, there is a lagging of kind of incorporating contingency management in some of our treatment. I work in the CDOP, which is a chemical dependency clinic, and sometimes it's hard to implement some of these things. So we have a very special guest, Dr. Dong Chan, here with us today, and we are so excited to have him here. So bear with me. I'm going to call him Dr. DC part, right? And I think we can all call him Dr. GC. So Dr. GC got his medical degree from the Rosalind Franklin University of Medicine and Science. He went on to finish general psychiatry residency at Boston University Medical Center. He went on to complete the addiction and psychiatry fellowship training, also at Boston University Medical Center. He's a double alum. Woohoo! He is now an assistant professor in the Department of Psychiatry in the Tribanian and Avedisian, I don't know if I said that right, but I think I'm very close, School of Medicine in Boston University. He is a faculty of buprenorphine master course. You heard that? It's a master course. So just be ready. You may get a little mini course here and there throughout in the annual meetings at the American Psychiatric Association in the last 5 years. So if you're going to APA, you may want to go take a look at Dr. DC. He also works in Bedford Veterans Affairs healthcare systems. And today, we are so happy to have him here. Dr. DC, please welcome.
Thank you for having me. I'm glad to be here.
Perfect. Thank you again for coming. So today, Dr. Park is here to help us discuss stimulant use disorder and its management. We're going to look at a 2025 cohort study that was published in the American Journal of Psychiatry. And it's basically asking a very critical question. Does contingency management, an intervention that's built on behavior reinforcement, do more than improve abstinence? Could it actually reduce mortality? So this is what we are going to discuss today. And here are some findings to frame today's discussion from this literature. It shows that participants actually receiving contingency management had significant lower all-cause mortality compared to matched controls. The other thing is also that stimulant-involved overdose deaths. This is from CDC and AMA. They're showing that the stimulant-involved overdose deaths in the U.S. have actually increased fourfold since 2010. So we have an increase in fourfolds, but we also have literature showing that there is some form of treatment that can actually help decrease that mortality. But despite being one of the most evidence-supported treatments for stimulant use disorder, there are gaps, and we're not really using contingency management as much. So if contingency management saves lives or can save lives, what is your thought about all of this? Why is there a gap and why are we not using it as much?
I think fundamentally there's a reaction which causes stigma against actually the contingency management, that we are actually providing financial incentive or money incentive or voucher incentive intervention for people to stay abstinent of stimulant use disorder. The most common question that I hear from people is, aren't you bribing them not to use drugs? Aren't you just giving away money to not to use drugs? So it's kind of hard for people to accept. Second, even from the hospitals and the program side, it is not so much an attractive option because so far we have not had any robust reimbursement coding and system to reward hospitals and programs to have contingency management. We still make it happen, we still make it available, but it is not like doctor prescribing medication and for each visit, for 15-minute visit, you can bill for this amount of money and hospital can actually benefit from it, or to have a therapist to provide cognitive behavioral therapy, the substance use disorder, time-limited 12-week session. And that would reimburse the hospital a lot more. So even though the contingency management is probably the most economical and most efficient way to provide treatment for stimulant use disorder, I think those two factors, first one, I don't want to bribe my patients, or I don't want to bribe them for not using drugs. And the second, can I make this, I don't want to say profitable, but can I make this to help our organization sustain our operation?
I can only think of some of the people that I see and saying, hey, I'll give you, there's this amount of money if you stop using what you're using currently. Just how that makes me feel as a provider, as a clinician, I'm like, I don't know. I would definitely feel some sort of voice. I could see how that can play a role. And I definitely also see the point of not having the vast evidence to support everything. So like hospital systems actually doing the program, seeing how the long-term impacts all of that, or even the comfortability, much studies about the comfortability of the providers actually implementing these things. Because there's a lot of research out there, which is how this podcast was birthed, how they don't feel comfortable just talking or treating addiction in general. So then think about adding a piece that feels like bribery to whatever management that you're giving people. I definitely understand that. Could you tell us a little bit about the conceptual framework of just contingency management? So for the people in the community that may be listening or other providers that are not really clear on what that means.
So the basic foundation principles of contingency management is simple. Patients usually come in to see their providers but with a target goal, and it may be to increase the group rates, group attendance rates. It may be to increase the adherence to their antipsychotic medications. It may be to decrease the use of stimulants. And so there's also additional evidence that the contingency management can also help people with the adherence to extended release intramuscular naltrexone injection. So people come in for those target behaviors, and the concept is to provide them with either money incentive or voucher incentive every time they reach a target. And it increases the likelihood that they will reach the target behavior. Now, why does that work? Because if you look at it fundamentally, it comes with the consideration for delayed discount, or people are a lot more familiar with delayed gratification. So I think everyone knows that study. Kids who are told they can have one marshmallow right now, but if they can wait 15 minutes, they can have two marshmallows. And those kids who can wait 15 minutes to get two marshmallows, they tend to do better in their lives. When you look at patients who are suffering from substance use disorders, you can see how that their ability to wait for the delayed gratification is compromised. They all know that yes, not engaging in substance use, not engaging, not buying cocaine, not buying methamphetamine right now will result in, better finance for me, better relationship for me, more likelihood that they could get a job, and more likelihood that they will keep their health and their lives. Their immediate gratification to look for the high or the euphoria is right then and there. We see that repeatedly, those patients, especially with chronic substance use disorder history, their ability to hope for the delayed gratification is compromised. And we are hoping that in contingency management, by having them get immediately rewarded, and well, not immediately rewarded for making a choice to abstain from substances, but getting immediately rewarded for providing a urine specimen that's negative for the substance can actually help them reset their neurochemistry to be able to appreciate, to be able to have an ability to appreciate the delayed gratification. So how that works is that the patients will come in usually 2 or 3 times a week and give a urine specimen. And this is actually one of the critical steps. You don't want to send the urine to a lab and wait for 30, 40 minutes to give them a reward, because we all talk about how there's a temporal association between their ability to change their behaviors. The rewards should be as immediate as possible. So they come in, give a urine specimen, and it goes through the point of care testing, like a urine dipstick or urine cups. And when it's negative for the substance, target substance they're trying to abstain from, then they're given either a straight up voucher or money, or to be given a voucher to be given a chance to win a prize. And twice a week, 3 times a week, that goes on for 12 weeks, which is 3 months, and has shown to actually have, even after the completion of the treatment, obviously during the treatment, it shows actually a lot of evidence for patients to reduce their stimulant use disorder. And even after the studies too, even after the study periods after up to a year, they have shown prolonged benefits. And in this article, it also shows that the all-cause mortality is also decreased significantly as well. And I think the authors did a very good job of making sure that this was an all-cause mortality, because I see this in practice, and I'm sure you see this in practice too. You hear a patient passing away, but you don't know the cause of it. And it's not like you can ask around either. If they have been struggling with the substances, then you kind of feel for them and you have an idea, but you cannot ultimately know. So I think by investigating the all-cause mortality, it reflects our more real-life practice. And to see that it even decreases the all-cause mortality after going through this contingency management is very, very encouraging.
Absolutely. And from what I'm hearing you say is that contingency management is grounded in some form of operant conditioning. And it's also connected to the reward pathway, because using the substance is already caused some cycle that we're trying to kind of change. It's a change in behavior that we're looking for, and a change in the chemistry of the way the mind, the brain is doing things. So connecting that operant condition where that immediate tangible reward is being given to the person, and the feeling they get is similar to the feeling they would get if they use. So I think it's such an amazing tool to have for people. What came to mind for me was how it compares different psychosocial interventions that we may have. And if there's been any studies or anything that's been tried and how that compared to contingency management, especially when we also look at the all-cause mortality.
I don't think I've seen the head-to-head trial between contingency management versus cognitive behavioral therapy for substance use disorder. I do know that when you combine the contingency management with the cognitive behavioral therapy for substance disorder, is more beneficial than contingency management alone.
I haven't seen any myself either. Just looking up different literature, I haven't come across anything. I'm going to do more research to see if there's any trials that's in the work that may be registered somewhere in some great literature that I haven't had seen, but I haven't seen anything. But I do agree with, even in practice, seeing how people going to group therapy, getting some CBT or different supportive services in addition to the contingency management or different treatments actually help more than one alone. So definitely, I have seen that in practice. So I'm agreeing with the research right now.
And that's what we do in our practice to people who are coming into our partial or IOP. They're still going through the program. They're offered individual counseling, and contingency management is offered on top of everything. It's not offered in lieu of anything else.
No, absolutely. And I think that idea of adjunctive treatment per se, or just concurrent treatment of that. What would you say as clinicians, especially, I know when we started speaking, we were talking about how we feel about the bribery and that culture or stigma that may be associated with contingency management. How do you think, what are the ethical concerns that clinicians may have, and how can we address some of these?
So I certainly get where they're coming from. I do think that the amount is nominal, at least in the American healthcare system. I think up to $600 a year or $750 a year because of actually the tax purpose. But we're still seeing a lot of evidences with that amount of money. It's going to cost tens of thousands of dollars for us to offer hospitalization to a patient. Already, the American healthcare system is spending a lot of money into taking care of one patient. So I think when you look at the economic side of it, I think it's actually the more economical forms of treatment. On the other hand, how do you combat the stigma about, aren't you just offering bribery? So I think the amount also works. If I'm offering $100,000 for a patient to abstain from cocaine, I think that's going to be a very, very complicated matter. And then this is something that I preach to my staff and my trainees too. We want to have a pragmatic approach to our treatment, whatever works. When it comes to treatment, there might be a patient who can benefit from having disulfiram for their alcohol use disorder. There might be a patient who can kind of benefit from attending partial hospital. There might be a patient who benefits from having the sterile syringe pack, program. So we are incorporating any and everything that works for the patients, and I'm not tied into one particular approach. For example, buprenorphine is my favorite medication. I love helping patients with the opioid disorder with the buprenorphine, but I'm not tied to that only one modality of treatment. Whatever works for the patients, and if it's in my control, I want to mobilize it. I want to incorporate it into treatment. And I'm thankful that my hospital has a contingency management.
Absolutely. But I completely agree with you. And I'm thinking about patients, the stigma, all of that. And I'm such a huge proponent of recovery-oriented care and trauma-informed care in general. So I'm thinking, how does all of that play a role in how effective any contingency management or any other treatment or management you're using for stimulant use, right? Like you said, you may have buprenorphine, which you enjoy using, but it's not the only thing you're using. So I guess this is a two-part question, now that I'm thinking about it. One, is there any other medications or treatments that you're using for people that you're seeing for stimulant use disorder? And two, what's the role of trauma-informed and recovery care in that?
Yeah. So as you mentioned, there's no FDA-approved medications for cocaine use disorder or even methamphetamine use disorder. There's some evidence for naltrexone, bupropion, mirtazapine. Those are all, by the way, as we've said, non-FDA-approved medications for stimulant use disorder. For patients with the comorbid ADHD, I think there's a very strong evidence that the treatment with the high-dose amphetamine or methylphenidate can be beneficial for those patients. And if I diagnose ADHD in those patients, I'll, of course, start with the non-stimulant treatments first, like atomoxetine or bupropion, and even modafinil or armodafinil can be tried. But if their stimulant use disorder is not decreasing, or if their ADHD is not improving its symptoms, then I'll go with the amphetamine or methylphenidate treatment with actually very careful monitoring. I'm not just sending them out with a 20-day prescription. When I'm first starting them, I want to try to get their ADHD diagnosis correctly by getting some collateral information with the more careful interviewing. But when I'm first prescribing those stimulant medications, I'm going to be give them only 1 week supply at the first time and have them come back and give another urine specimen. Of course, if it's especially stimulant use disorder, I also want to rule out that there's no other compulsive sexual behavior disorder that accompanies the stimulant use disorder, and try to incorporate some counseling around that too, because otherwise I'd be missing a very, very big piece of their desire to use stimulants. When it comes to trauma-informed aspect for contingency management. So contingency management is entirely voluntary, obviously. And the only thing that I can think of is that the contingency management, it actually makes, at least for my hospital, it makes a point that it should be non-observed urine collection. Because observed urine collection, there are instances where that has to be done, and that can be actually very much re-triggering of their trauma, especially if they perceive that as a coercive, if they feel that it is an invasion of their privacy or their sexual autonomy. And this is kind of beyond the scope of our talk, but I did partake in part of the write-up and the protocol for collecting observed urine specimen with the trauma-informed approach. I think that most importantly, you tell them exactly what you're going to do. You ask for consent and you minimize the observation time, because I know some observation protocol calls for the observing the entire duration of a urine specimen. I argue that it just has to be very, very as minimal as possible, just to make sure that it's not coming from a different specimen. And that is only when you have to collect the observed urine drug screen. But for contingency management, it actually specifically states that it has to be non-observed. So it kind of promotes the patient's autonomy and their privacy, and also incorporates the trauma-informed care to the aspect.
Absolutely. I think it's always important giving people agency in their care, giving them the ability to advocate for themselves, to not feel like someone is watching over their shoulder. Even them coming for the treatment, it's voluntary. Most of what we do are outpatient. They're choosing to come. The people that come for intake and never show up, or people that always get rescheduled and never show up for the intake. So when people even show up, I'm always happy and giving them that vote of confidence and be like, hey, you did it. You got out of the house, you made it, or you picked up your phone to do virtual, right? I think it's important to making sure people still have some form of agency and privacy. I used to volunteer for my university health center, and one of the things I would do would be drug screens for some of the athletes. It'll be very early in the morning, and we actually had to be right there. Like, we didn't have someone not watching and doing all of that. And I can see how that can, especially for someone that's having stimulant use and all of that. One thing that you mentioned is the sexual desires that may come with the stimulant use. Are you able to talk a little bit about that?
Sure. One of the couple of follow-up questions when you're doing the intake for patients with the stimulant use disorder should be what forms of drugs they're consuming. Are they smoking crack or crystal meth, or are they injecting melted crystal meth? And obviously, if they're using IV, then you want to provide overdose prevention counseling and also the infection prevention counseling. If your hospital has it, provide them with the sterile syringe program as well. And it's also interesting because some patients will tell you, when you ask them if they're smoking crack, they'll tell you, no, I don't smoke crack. I only use powder. There's a tier of stigma, even among the patients with the substance disorders. But a lot of times I ask them, when you're using stimulants, are you doing any risky behaviors or sexual activities? Because some of the patients will tell you they'll watch pornography when they're high, and only when they're high on stimulants, or they tend to use the sex workers. And now some of the patients have so much ingrained that into their routine. They will tell me that they cannot now get sexual orgasm without using methamphetamine or cocaine. If they're just having sex, or they're just masturbating, watching pornography without stimulants, they cannot achieve orgasm. Now, this introduces a whole different angle, because you can have them go through contingency management, you can have them go through cognitive behavioral therapy for substance use disorder. But if you never knew that those patients, why they're relapsing every week is because they got their sexual needs and urges, and they don't know, and they have any other means to meet that need without resorting to using stimulants, then that's a huge part of the treatment that you're missing. Obviously, there's only limited things that you can do, but you can also approach them with how we can promote and encourage meaningful, intimate relationship that does not involve using stimulants together. If a patient is talking about their ex-partners that they have had sexual relationship with while using stimulants together, and they're now getting back together with their ex, and I express my concern for them that the risk for them to relapse into substance use disorder will be elevated.
It sounds like, as always, with anything in medicine, finding out the underlying cause is very important, because then, regardless of the treatment, if that cause is still there, it really won't make much of a difference. So thank you so much for answering all these questions and being readily to answer even the ones that I was more curious about. So for our next segment, it's a case presentation. We have a 41-year-old Alex that's coming in with severe methamphetamine use disorder, multiple non-fatal overdoses, housing instability, repeated disengagement from outpatient care, and traditional counsel-only approaches have sort of failed and not really been the best for this patient. So for the clinicians and the trainees that may be listening, how would you assess readiness in this case and the appropriateness for contingency management?
So one thing I love about the contingency management is that it's a low barrier. They kind of have to commit to come every so now and then, but they don't have to, because a lot of patients are now feel like they're coerced into group therapy or individual therapy. And I think one rule about therapy is that you don't ever want to force someone into therapy when they're not ready. But they don't have to share anything about their traumas. They don't have to share about their struggles. If you can only ask them, hey, we'll still treat you if you show up to us. You come twice a week, give urine in and out 20 minutes. But if you give us a urine that's negative for cocaine or methamphetamine, you'll be given a chance to win prizes. And what do you say? And they actually got nothing to lose as long as they don't have any logistical barrier to come in, which is actually one thing that I wish that future research of contingency management can address. Is in my practice, probably the biggest barrier for contingency management is the logistics. If patients cannot make it into hospital twice a week, then they can't, even if they want to. So there was some study on the remote monitoring of the drug use via oral saliva sampling. And what they've done is that they'll have done the oral saliva testing and they'll show it on the camera. But if that can be incorporated, and if you can be given an authority to send them a prize for producing oral saliva sample and show them on the video and it's negative for methamphetamine, I think that'll actually increase the engagement of the CM a lot.
When you were saying that, I was thinking about a clinical trial I was working on, and most of what they were doing, the monitoring of the patient was remote, where they had an app and the patient would log in and someone would watch them all of this. So it's very possible to do that for this as well. Somebody somewhere has the technology. We just have to translate it into this setting to be able to use that. How would you say contingency management can be integrated into a multidisciplinary care?
So multiple non-fatal overdoses. So I think that the priority should be medical provider meeting with them to talk about how to prevent overdoses, how to keep themselves safe, talk about national hotline so that if they don't respond while on the phone, the hotline can call the 911 for them. And housing instability, homelessness, obviously it affects the outcome of health in multiple different levels. So getting them into some sort of a housing voucher system, with or without vocational rehab, they are willing to participate in and offer them homelessness service as well as vocational rehab, be very helpful. And I told you one of the biggest things for me when evaluating patients with a substance use disorder is to diagnose, to explore if they have undiagnosed ADHD. And if they have ADHD, then by all means, you should treat it. I'm not saying that you should jump to treat it with the high dose amphetamine or methylphenidate right away, but you should still explore and properly diagnose and go through medication trials. And if they want to, then get them into cognitive behavioral therapy for substance use disorder or refer them to partial or IOP, intensive outpatient program.
I think risk management is one of the most important things that we do for our patients. For someone that's going into a community psychiatry or public psychiatry fellowship, social determinants, it's
Yeah.
what makes me want to do the work that I do and the population I focus on most. So when you talk about housing instability and all these different things being addressed, I'm like, yes, how can policymakers help with everything that we're doing, right? Because you've mentioned barriers. I'm sure there's some policy barriers, whether in the state level or federally, that's sort of limited how much we can help people or how we're helping people. So if there's any policymaker or anyone that can help in that setting, any advocate, what would you say? What would be the education for them?
So I think at least for the Veterans Affairs Hospital, they've changed the homelessness service, actually changed the directive about 15 years ago. It used to be that the patients had to demonstrate clinical stability or at least, willingness to engage in treatment. They've changed their directive about 15 years ago, said housing first, because they've seen overwhelming evidence when patients have stable housing, it produces better outcomes for the health. And it changed the dynamic because before, patients felt like having a housing assistance was more of a privilege. You had to earn it by demonstrating that you're a good patient, that you're willing to do all the work and you're willing to abstain from substances. Yeah, they do the right thing and they get rewarded with the housing assistance. But in real life outcomes, we've seen that approach actually fails a lot of people, and a lot of patients never achieve being good enough patients to be eligible for housing assistance, and or they feel coerced, or they're not ready for it, they're not engaged in it, and they have poor outcomes. But when the policy changes to housing first, no matter what, then it actually improves the overall healthcare outcomes and actually more savings in the long run as well.
I think a lot of what we do, whether it is prophylactic treatment, interventions, trying to prevent different things, I think most of the time what they need to see or the policymakers need to see is the cost effectiveness of it in the long term, is how all of this, as the study shows, actually decreases the amount of people that are dying from it. And regardless of where we fall in all of this or what your role is, the end goal is to save lives, is to make sure people are living their healthiest and best lives as they can. We're coming to the close of all of this, and you've taught us a lot, and I've learned a lot of stuff that I didn't even know, and I'm ready to go back and learn. But for someone that through all of this in the end, they're like, oh, I heard these things here and there, but I may have missed some. Not to put you on the spot, but if I gave you 3 to 5 minutes to do a mini crash course on, they will use disorder and contingency management.
Yeah. Contingency management works. Actually, it's the best treatment for patients with cocaine use disorder or methamphetamine use disorder. It's actually very simple to deliver, and you get training. Well, obviously, you have to be supervised for a number of sessions, but the initial intro to contingency management is very short. And the actual intervention, maybe 10-15 minutes. Collect urine, test the urine for presence of cocaine or methamphetamine. If it's negative, you give them a voucher or financial incentive and you congratulate them. If it's positive, then you kind of hear, how can I help you with the help giving a negative urine the next time, and see if there's other help that you can kind of get them. And it's based on the principles of resetting their gratification, their ability to appreciate the delivery gratification, and which is compromised in the world of substance use disorder. There are many barriers to provide contingency management, from the stereotypes and stigma, and from also the reimbursement standpoint, but it's nothing that we cannot overcome. There are many hospitals and organizations that already provide a lot of contingency management. So find out more about it. Volunteer to take one patient with the contingency management, because that's the best way to learn it. And yeah.
Thank you so much for this. We've learned a lot. I've learned a lot. I don't know about people at home. I hope they learned stuff, but I've learned a lot. So for the clinicians, if you haven't learned anything, I want you to take one thing away. It's that contingency management actually works. So when you can, please use it. Bring in all your different people that you work with, the therapist, the case management, all of that. It's that translational care that you could get for someone. So use it when you can. If you're a student, this is literally just challenging that non-traditional management that can work. We're like, oh, we're bribing patients. Really, no, we're not bribing patients. We're trying to save their lives. If you're a trainee, this is one evidence-based thing that you should know. Add to your list of things that work for patients. Contingency management's actually working for them. And if you're a policymaker, just like the VA has changed to housing first, that's something you can do as well. You can implement different policies that can put the lives of people first. That can help the clinicians and what they're doing, the social work teams, the case management. As much as we're learning, it's also a form of advocacy to call out on people that are able to stand up for the people that we care for and make sure they're getting the best care possible. So thank you all so much for coming and listening. And if you're part of the general public, I hope you pick something up, that we do have treatment that actually works for you. If you have any trouble, know that we are here to care for you. We are here to help, and not to make you feel like we're judging you, or we're taking away your rights or your privacy. So just know all that we do and every step that we take is to try to get you the best care that we possibly can. So thank you all today for listening, for coming. We want to give Dr. Park a chance to shout out anyone that he wants to. If there's any work he wants to highlight, I will highlight one for him. If you're going to the APA, please make sure you're going to the buprenorphine master course. I am going to probably sign up for that because I need to learn a lot more before I go into fellowship. So Dr. Park, the floor is yours.
Thank you. Thank you for this time. And I actually didn't prepare for this segment. Other than, if you're coming to APA, maybe hopefully I'll see you there. But otherwise, I'll let you know if I come up with something later.
Of course, if you come up with something later, let me know and we will plug it in on the website, on our Instagram, or any social media pages, on our YouTube page, wherever. We will plug it there for you. So thank you so much. We truly appreciate you for coming. And for those listening at home, thank you for listening. And as always, stay ready, stay aware, and stay grounded. Thank you.